Hi, I'm going to be in the middle of feeding my dogs every now and then as we go along. So if you hear a scrabbling noise, it's just dogs desperate for biscuits. The point about today is to give people a good chance of being able to put together an effective clinical case report that gives you a good chance of getting published in the International Journal. My name is Glenn Waller. I'm the associate editor who takes on all the case reports, single case designs and case series work. So essentially, if you've got interesting clinical work, we'd like to know about it. But what I want to do today is to talk to you about ways of making that a more effective submission, a better experience from your point of view. Now, my plan is to talk for maybe half an hour and then take any questions, and it might be questions you've got in principle. There might be questions that you've got which are very practically about your piece of work. So if you've got questions, do type them as you're going along. I'm happy to pick them up if they're important to pick up during. But if possible, I'm going to save them till the end and then just go over them. So maybe if you think I've missed one, jot it down and write it, type it up again for me as we get closer. Okay, I'm not sure where everybody is. It's 10 o'clock in the evening here, so hopefully we're managing to get to a good element of the world just by talking to you from my dining room. Right, I want to start out with some real basic stuff. So I'm going to try getting my computer to actually move good. The first thing that we're after is a clear goal for the editorial team, a clear goal for the journal. What we want is the best possible understanding of the pathology, the patient's experience, and the treatment of eating disorders. This is not because we like running a journal. Running a journal can be a real tiring job at times, which sounds a bit self-pitying, I'm afraid. But what we want is our patients to get the best deal. We want to get good services to people. We want to get good ideas to people. Now, the bulk of what we publish in the journal is a combination of empirical papers and review papers. Sometimes we have a special edition or a themed edition, but mostly what we'll see is papers which are big studies or big reviews. But really critical here, what we need is new ideas. Now, I don't want you to tell anybody I said this, but sometimes you've got to think the world cannot carry on being run by boring old grey-haired men like me. Every now and then it needs new ideas to come through. And so the journal has two particular kinds of publications that support that idea, that support innovation. One is a category of papers called An Idea Worth Researching, where someone puts forward a new idea and proposes a line of research that might be fruitful. And it's a really interesting little category of papers, that one. We don't publish many, but the ones we do tend to be really good ideas that you start seeing popping up. I can think of a couple of such papers where, you know, I use that kind of idea in my everyday work, in my clinical work, in my supervision, and in my research. But the one I want to talk to you about today is clinical case reports. And the reason I'm really interested in clinical case reports is it's because where nearly every good idea you come across has started out from. If you think about it, you know, you think about clinical research, you think about clinical treatments, they don't start in a lab. Most of the time, they start in what we might call the real world. They start in, you know, with ideas that clinicians or researchers have that sound a little bit balmy when they first think of them, and they try them out, and suddenly they've got something that needs growing. Now, in terms of what Paul Salkowskis talks about, he talks about research being a kind of hourglass. You start wide, you narrow down, and then you widen out again. Now, the bit in the middle is the kind of the big studies, the effectiveness and efficacy studies. Down here, we've got to spread it out to the rest of the world. But up here, a lot of the ideas are things that came in a clinician's kind of inventive moment. So what we want is more inventive moments. We don't want balmy, but we do want good ideas that give us something to go on. So again, think about Freud, think about Beck. They didn't start out as big labs. They started out as a clinician having an idea. And that's what we want people to kind of grow for us. New ideas about treatment, whether it's biological, physical, psychological, or whether it's about understanding the pathology, understanding problems that patients have. These are things we can do by getting you to think, what could I add to this world? Now, there are 3 kinds of clinical case report. I'll go over those, but mostly what I want to do after that is take you through how to do it. And I'll give you a warning. How to do it involves a very strong element of how not to mess it up. So I'm going to talk to you about how to do it, and I'm going to talk to you about how to mess it up, and I'll leave you to make your choice at that point. First up, we have the single clinical case. This is the most common of the ones that I'll be talking about. Usually you've got a case who's got maybe a new presentation, a novel piece of pathology. For example, a patient finds a new way of trying to lose weight that we haven't encountered before, that's very rare, and it starts picking up. Then we'll often publish a case like that that says, look out for this. Clinicians, be careful. So if I was thinking about examples, things like there's been a recent growth in the use of things like metformin. And initially that's a new thing for us to look at. So we'll think about, if a good case comes forward that will teach us something, we'll consider that. Or it might be a whole new treatment. It might be somebody saying, you know what, I've worked out that if you do this, then you can get a better response out of 1 or 2 patients. So let's try that a bit more with a larger number of people. And that, again, if it's novel and if it's got what we call heuristic value, if it teaches us something that you can apply in your research or your clinical work, we're going to be interested. Again, innovation. The ideas that don't come from old farts like me, but from newer minds, if you like. The second type of clinical case report is a small case series. A few cases that point in the same way, or that point in different ways, but make a single point. So recently, for example, we've had, just purely as an example, somebody putting together a paper, looked at 3 different presentations of ARFID and looked at the overlap in the treatment, because ARFID's a fairly new thing, we don't yet have much about it. And when someone can put that together, another clinician somewhere other side of the world will be able to pick that up and say, oh, I've got cases like that, maybe I could try that. And in time, that rolls out into more and more cases until we've got our full-blown treatments. Sometimes it doesn't work, and that can be useful to know as well. But for the moment, let's go on the basis of something with novelty that will communicate to other clinicians, other researchers around the world. The next kind of presentation that we look for, and these are probably the rarest, are what are called single case experimental designs. Now, I cannot stress strongly enough, if you've got week by week data and you maybe had a period where you weren't treating the patient and then a period when you did, rather like the diagram that's up here on the right hand side, you could be in a very good position to teach us something. Because one thing about single case experimental designs is that they are effectively very nice pieces of work to learn from. So if you've got that kind of data set from a case, it's worth thinking about, is there a way of turning that into something that uses rigorous designs to show a strong conclusion about one case? It will never be as big as a major study, but it gives us something that says, oh, we should pay attention to that. The issue with single case experimental designs is you've got to be thinking about them from the very beginning. It can't be something where you think after the event, oh, well, maybe I could have done that. It's got to be something you planned as you went along. So what we're looking for there is, were you clear about what you were doing from the beginning? If so, this is a much more attractive design for the journal's sake, because it just gives us more to work with. So those are the kind of 3 general types of paper that will come to me as the associate editor. Now the process is, they come to Ruth as the chief editor or the editor-in-chief. She then distributes papers to myself or the other associate editors. And the ones that look like this will come my way. Sometimes you get ones that are called clinical case reports and they turn out not to be, but usually these will come to me. So that's, what you've got to imagine is if you do this, it's going to come to me. and I'm a mean man. Yeah, so I'll be looking to get the best possible outcome. Now, the reason I'm raising all this is that as an editor, it's a sad life. It's a sad life partly because you have to reject a lot of papers. The IJED has a lot of papers submitted. Probably out of every 10 papers that get submitted, maybe 2, maybe 3 will get accepted in the end. And nearly every one of them will go through review, another review, a revision. In other words, you don't just get in. It's a hard door to open. But when you've got it, it's great for your CV, it's great for our patients' benefit. So we do like people submitting all of the different categories of papers. So when a clinical case report comes in, Ruth will pass it straight to me. I will read it. And this is part of kind of general journal policy, like nearly every journal. We don't just send stuff to reviewers, because if the paper is very weak, we hack off the reviewers. We upset the reviewers by sending them something where they're having to go, why did this ever come to me? So part of my job is to stop stuff going to reviewers that is either too weak or that fails to meet the core criteria, but could be revised. So I might say, this won't work, or I might say, you're going to have to resubmit this, actually doing what the journal said you should do. So pay attention to what I'm going to talk to you about in terms of the kind of criteria, because once we have laid down these criteria, we're going to judge everyone by them fairly. So, will the paper go to the reviewer? If it's good, yes. If it's got any minor presentation problems, yes. If it's one where it's obviously good, but I don't understand it, and let's be honest, I'm a psychologist, there'll be some medical ones that I'm not going to understand. If it's understandable at a very basic level, then I'll pass it on as long as it's good enough. But if it isn't, it's not even going to get to the reviewer. Now, the problems that papers have when they come to me mean that, and this is a kind of broad picture. If 10 papers come to me, and that will happen some weeks, it won't happen other weeks, but if 10 papers come my way, I would say on average, I send about 4 of those straight to reviewers. I write back to about another 3 authors saying, this really doesn't meet criteria for a single case study, or it's not new enough, we're not going to consider it. And about another 3, I send back to the authors saying, this has got potential, but I cannot send it to the reviewer in this format. And I'm going to go through some of the problems. Because you know what? I don't need the work. You don't need the extra work. And if you're going to write it, it's as well to write it correctly the first time. And that way, none of us have the extra work. So I'm going to try giving you broad hints, which are all in the journal guidelines, but I'm going to try to bring them a bit to life for you. And I'm going to try to point out the difference between the simple problems and the complex ones. Because occasionally an author will write back to me and say, well, you're telling me I haven't put any of that information in, but I've got it all. Unfortunately, I'm not psychic, and nor are the reviewers. So if you're not putting it in, don't expect us to know it. And I know this sounds ridiculous, but that has included material like, for example, people not telling us anything at all about the eating disorder. They tell us about something else, but in someone who they say is anorexic, and they haven't told us whether the person actually is anorexic or not. So it needs you to think communication. And like I say, if I can see the potential, I'll send it back to you and say, okay, now get these points addressed and we'll take another look at it. I won't guarantee that it will be good enough to send out, but I will at least give you another chance at it. But I don't like wasting your time. So if it's really never going to make it, I'll tell you. If it could make it, I'll tell you. And if it's good enough, next thing you know, you'll be hearing back from the reviewers. So the broad picture is, if you haven't heard back inside a week from me, and probably within a couple of days, it's gone to the reviewers. Once it's gone to reviewers, we try to get stuff back within maybe 2-3 weeks. So you won't be waiting too long. One really key thing to remember about the International Journal is we really aim for quick turnover. Compared to some journals, it's a terrible secret to admit, but I put stuff into journals and sometimes it gets rejected. quite a lot of times it gets rejected or it comes back for revision. And sometimes, I think my record so far is I've had to wait over a year. We don't do that to you. If our reviewers aren't returning the reviews, we start chasing them. So most will come back to you probably within about a month, roughly, usually a bit quicker. However, then you've got all the revisions to make. And like I said, mostly things have revisions to make because none of us is perfect. So what I want to do is I want to give you an idea about what is it that I need to do to get reviewed. In other words, what do I need to do to get past Glenn before it even goes to the reviewer? And how do I do well enough that it gets to the reviewer and I've got a really good chance of being accepted? So that's my point. That's what I want to get to, because I want to give you a really good chance of getting your stuff published, telling the world about it, getting some of those innovations out there, because once in a while, there'll be an innovation that will really make people stand up and go, oh, I should try that. That sounds like a really good thing. And it's just so valuable to be able to say, I put down an idea that occurred to me in my office, and 2 years later, 6 months later, somebody on the other side of the world thought, oh, I could try doing that. And the idea that you had is getting spread around just by mere fact of you bothering to tell people about it. One of the big issues I have about research is we keep reinventing the wheel. If I invent an idea in my office here in the UK, and I don't tell anyone about it, someone else has got to invent that idea in Spain, and somebody else has got to invent that idea in Albania, and someone else has got to invent it in California or Japan. It could be that we've all got to make this idea up when just being able to read about it would be so helpful in the first place. Okay, so as I go, like I say, raise chats, chat questions as you go. At the moment, I'm sitting on a say hi to the dogs question from Carly, but hi dogs. They're looking really, really baffled by this. So let's start with my big headers. Now you'll have access to all these slides, so please don't feel that you've got to sort of jot all this down. You really don't. I want you thinking about this stuff. So my big categories are, well, my big categories and how to get it wrong. They're not just all about push at the door that says pull. When we plan after the event, when we summarize the material badly or inadequately, when we present the paper poorly, and when we make it really hard to follow. Now, number one is difficult to deal with after the event, especially if you want to do a stronger design. It's doable, but it's hard. The other ones are all really easy. And I would really hope that the learning about some of the things to avoid would be a really good thing. By the way, a question's just come in from Alexia about whether case reports are reviewed in the same way as the research articles. The answer is yes. They all go to more than one reviewer. You get back feedback from the reviewer, which will address some of these points. So yes, you will get reviewed, you will get feedback, etc. Right, planning after the event. I like this picture. This is a picture of people taking photos of wildlife. And they're taking photos madly and they're all focusing in one direction. Whereas the big thing, the elephant in the room, as it were, is just standing right behind them and they haven't noticed it. Now you just know that in about 30 seconds time, someone's going to scream, someone's going to fall off the bonnet of a car, and they're going to realize there is an elephant there directly behind them. But they won't get a good photo of it because they won't be prepped for it. So what I want you to do is to think about looking at things from different angles at the same time. So, for example, here's a really common experience when I'm reading case reports. People write about the case when the case is not that novel, but where something went wrong. And they try to make it clear that it's the case that's the interesting bit. Sometimes, and I'm sorry to say this, sometimes as clinicians, we mess up. We don't do something when we should. We miss a point that was really important. And as a service or as a clinician, we hold on to the stuff that we thought was right. And it's only 6 months later that we look back on it and we say, do you know what? The problem there wasn't that the patient had something new and exciting. The problem was that we messed up. Now, that is not in itself a bad thing from a learning point of view, because we always learn out of messing up. So what I want you to get used to is the idea that if you mess up, that can be a really interesting case report in itself, where you're talking about the way the service missed something important. As an example, one of the things I always advocate to my trainees, in therapy for an eating disorder, we always weigh the patient ourselves in the room during the therapy session. And sometimes services set themselves up so they don't do that. So maybe a dietitian will weigh the patient, the therapist will see the patient, and they never connect that information. That can lead to patients losing lots of weight and nobody notices the problem about what's going on in therapy. That is a really interesting observation. It's got nothing to do with the patient, but it's got a lot to do with how the service is configured. If I got a case report that said how we messed up and how we learned from that, I would be thinking, do you know what, that is interesting. That's worth telling people about. So it's not always about the interest lying with the patient having something completely new. It could be with the service realizing something completely new it hadn't noticed before. But when you get to that point of realization, you've got to decide, do I have enough to explain it or make sense of it? Or am I just going to put down something that says, I think what was happening was this, but we really don't know. If you really don't know what was happening, you probably haven't got a good case study. Certainly not something that's likely to get into the international journal. But remember, sometimes you have got enough, you're just looking at it from the wrong angle. So next time you realize there's an elephant behind you, work out why you never noticed there was an elephant. Because all those people look like they're really interested in wildlife. They look like they spent a lot of money on the cameras and the trip. So what is there about what's going on for them that's making them think, oh, nothing else matters? That's a real issue in clinical settings. So again, don't always assume it's the patient who's the problem. It may not be. So the second of my 4 points is how you summarize your case material. Now, it's worth being very clear about what is new or what's rare. If you write something saying, here's an interesting case I've never seen before, and then you write a literature review that says, there have been loads of cases like this, or there are lots of papers about it, it's, again, probably not that interesting to the outside world, because while it's a good case, it doesn't tell us anything that we didn't know already. So you always need to think, what is new and what can the clinician learn from your case report? What might a researcher want to study further? And be very clear about that in the abstract as well as in the text, even in the title. Remember, the average person picking up a journal, international journal, whatever it is, will look at the titles. They'll look at the authors, and if there's something in there that interests them, then they'll look at the abstract. And only then will they look at the paper. So if you've written a really interesting paper, but an incredibly dull title and a really dull abstract, people may never get there and they don't learn from all your work. That's a bit of a no-no, I would say. Okay, next up. Do I know enough about the eating disorder to explain it to the reader? Now, this is going to sound really stupid, but probably the single biggest reason I turn papers around and say, we're not going to review this at this stage, is that they haven't actually told us anything much about the eating disorder. I was looking at a cluster of these last weekend, because that's when, I don't know if you know this, but editors do all their stuff at weekends because we do have other jobs to do as well. Don't necessarily do them well, but we do have them. Well, actually, all the others do them really well. I'm just under weak link. But of the papers I looked at last weekend, 2 out of the 4 had nothing about the patient's BMI, nothing about the patient's eating attitudes, nothing about their symptoms, nothing about their body image. It just said, this patient is anorexic and this was going on. So please tell us something about the eating disorder. Because sometimes you look at these case reports that are put in and you think, do you know what, this barely mentions the eating disorder. I once had a case that didn't mention anorexia, bulimia or any eating disorder at all. And I'm still not sure there wasn't a couple of pages missing from it. So tell us the basics. Even if you're not going to be looking at outcomes, tell us how the reader can know that this person has an eating disorder, how severe that eating disorder is. It only takes a couple of lines. But if you don't include that, don't expect it to make any great sense to the reader. Secondly, now that I know enough about the eating disorder, if I'm looking at outcomes, or if I'm looking at treatments, or if I'm looking at what happens across the course of pathology when a patient's got something really weird and new going on, what information do I need to tell people? So, for example, I want to treat anorexia nervosa, and I want to bring in a new treatment. But I'm going to be... The dogs have seen something, ignore them. The issue that I've got here is if you don't tell me the person's BMI and how that changes over time, or you don't tell me what happens to a particular biochemical reading, I don't know whether they're getting better. And again, it's very strange how many people don't include that information. So have I got the information? Can I give it over time? Again, I've had people reply to a review saying, I've got that information. I didn't know. I've just got no idea. And the stronger the information you give, the more likely you've got something stronger in terms of design, like a single case design. So always think, what kind of level of data have I got? How do I persuade people this is a really interesting intervention, or a really interesting piece of pathology, or really interesting biological disorder that I'm seeing within the eating disorders? And the answer is, give us the information, guys. Sometimes people present more than one case. And the question is, do you get anything new out of more than one case? Or is it really you're just saying the same thing twice over? It may be that you're able to say, yeah, but the fact there's more than one is really important because it says this is not an ultra rare or unique experience, in which case tell us. But sometimes when people do that, it's kind of like the shoehorning two things together, two cases that look quite different because they've got one single characteristic in common. Give yourself a chance to think, am I actually informing people this way, or would it be better with one case really well presented? You've got a limited number of words. You have 2,000 words to get this stuff across in. And you know what? I'm mean. I'm not going to say, oh, it doesn't matter if you've gone to 4,000 words. I'm just going to turn it back and say, you know what? You need to trim it down to 2,000 words. And most people can do it. They just kind of think, maybe it won't matter. We can count. And we have to make space for everybody to get an equal bite of the cherry. Next thing, I've already mentioned this to an extent. What's the real learning experience here? Patient is misdiagnosed. How did the misdiagnosis happen? Patient is treated poorly. How did that come to be? What was the team friction? What was the poor communication about? That is a case report in itself, because that tells teams how to operate better, tells clinicians what not to do. So be clear about what the learning experience should be. You could have a perfectly normal case, absolutely typical case of bulimia nervosa, and the team isn't working well. It's a team not working well, it's a novelty. Don't treat that as trivial. Really don't, because it is often the single most valuable thing that you can be presenting. If you try to skip over that, the reader doesn't learn so much. Nothing like so much. And now one of paying attention. This is where I get to really tell everybody off. And being brutal, it's not you. It's a lot of people who submitted stuff to the journal over time, have submitted papers that have been in really kind of quite poor shape. So here's a few rules to pay attention to. And if you ignore them, again, they're in the journal, they're very clearly there, but people often don't look. So let's think about what I would expect to see. Number one, there are very clear descriptions about journal formatting and length requirements. Lots and lots of papers go back because they're not formatted for the journal. They're not in good shape. Their spelling's all over the place. they're badly written, they're badly presented, I'm not going to pass that on to a reviewer, because the reviewer needs to look at the meaning, not at the copy, not at the proofing, etc. They need to be focusing much more on the meaning of what you've written, and they're not going to get that if you've written it badly. I can't afford to upset my reviewers. They might tell me, "Go away, Glenn. We don't want to do this anymore because it's too painful." To be honest, most of the reviewers have no idea how much we screen them from papers that they would be having a bad time with. They think we give them really bad ones. We don't. I would like to give them yours, just don't give me bad ones to play with. The other thing that you can do really wrong is prepare the paper for a different journal and then send it to us. So a lot of the time people send in things that are formatted with the wrong kind of referencing. They've got the wrong kind of cover sheet. It looks like it's been prepared for a different journal. They rejected it, and you're sending it to us without even thinking. That is not a way of encouraging us to think good things about you. It really isn't. So try to make sure that you give yourself, I'm trying to think how to put this, give yourself a fair chance, look at the requirements, and don't leave the editor or the reviewer thinking, this is just a paper that someone else rejected, why should we think good things about it? Or thinking, this author really doesn't care about this paper. Because I suspect by the time you've got to submitting this, your heart and soul is in this paper. And sometimes when you send in something that looks scrappy, it really looks like you don't care. A couple of very kind of particular points. Title page. Include the number of words. Just reassure us that this is in limit. Because sometimes we have to go through counting the words. And I think my worst example was somebody who didn't tell us what the word count was. And it was about 1,000 words over the 2,000 limit. Actually, that's not fair. The worst one was somebody who said 2,000 words, and it was about 1,000 words over the limit. We don't like having to count all the words, but we'll do it if need be, if it looks just bizarrely long. If English is not your first language, don't worry about it. Just get somebody who's good with their English to check it. And sadly, not all the ones that are written in bad English come from non-English speaking countries. So sometimes it's worth getting somebody to check what you've done in order to say, does it make sense? Can we read it? You know, is this saying what you really want it to? It's worth doing that before you send it to the journal. It will add a few days to the process. You're desperate to get it off the shelf or off your desk and into the hands of the journal. It will come back to you really quickly if you haven't checked it. So be careful about not presenting the paper in a really weak way. A few other points. Again, make your title, make your abstract meaningful. If they're not meaningful, if I can't look at it and say, oh, that's interesting, you know, a case of X in somebody with an eating disorder might well be interesting, but it depends on whether the X is a new thing. So stress that novelty, but also stress it someone with an eating disorder. Like I say, occasionally you read a whole paper and you think, did that patient have an eating disorder? They haven't really told us about it. They told us about the fact they've got gout or whatever it might be. They haven't told us anything about the eating disorder. Then when it comes to writing, give the context first. For some reason, a lot of people will write the case report and then we'll put a literature review at the end. Now, I'm aware that some, if you like, educational boards require this. We actually like to know what the heck you're talking about before you start telling us about it. So is there an existing literature on the topic? Have other cases been presented? Is what I'm presenting going to be new, or is it going to be just an addition that is worthwhile because it is an addition? Is it incremental? The reason I raise this is every time I read something with a big literature review at the end, I spend my entire time thinking, well, I don't know much about this area, but if this is new, great. And if it's not new, why are they telling us? So I start worrying that the literature review that's been put right down at the end is going to tell me all about how many cases have already been done with this, how big a set of research there is, the fact there's a couple of randomized controlled trials. And I think, you know what? I haven't learned anything that the rest of the world couldn't learn by looking at the other papers. So why do we need yet another paper? Why do we need your paper if someone's already published it? So give the reason for it being new early and stress that new stuff. Sometimes the discussion gets so lost that you forget what the new thing was. So again, that's important. It's also important when you're doing this to look at the concrete suggestions you can make for clinicians or researchers. You know, what do we need to do about X? Do we need to change how we set up our service? Do we need to change how we practice? Do we need to identify a particular problem that nobody's identified much of before? Are there new questions for research that are coming out of the stuff that you're doing? I don't know. You've got to think about that, and you've got to present those lessons, because if you don't, that will probably come back from review saying it's a good paper, but so what? Tell us what the lesson is. Okay, so remember, heuristic value, novelty. We want to know what is new and what can the clinician or researcher learn from that piece of work. There's lots of new stuff out there. There's an awful lot we don't know. It would be just nice if somebody was telling us some of it. And then the final one of my points, structuring your material clearly. Now, this kind of goes back a bit to what I was saying before. Because our patients are very individual, case reports are very individual. Because the problems they have are very individual, the case reports will be very different. But look at these as kind of broad headers to think about. I need an introduction, the context, the background, the existing literature. I need the case material. I need to know, does this person have this problem? What investigations? What was the treatment progress? Give me some information. That's what I'm calling for. The next thing that I look for is discussion. I want a discussion that tells me something about what is new here. I want to know what the lessons are. And don't put that long literature review at the end. It really won't help. If you wanted to do a literature review, put in a literature review. That would be a good thing. So to summarize, we want case reports. We want them to be excellent case reports. They don't have to be perfect. They do need to stimulate new ideas. So when you've got an interesting case, collect the data, work out what's new, look at the website for the IGED and say, am I meeting those criteria, and submit your paper. That way, we get to learn about what it is that you've done that could tell us some new stuff. And we need new stuff. Reviewers get to read it, I get to read it, we get good stuff to publish. And the IGED should be about good stuff being published. So now, I'm going to take your questions, but I'm going to beg 30 seconds. I need to go and get a power adapter. So think about your questions, type them up. I'll be back in just a second with the dogs trailing after me, I promise. I haven't run away. Right. Dawn, can you hear me?
Yes.
Okay, I've lost the visual.
It's actually down on the bottom of your screen, the PowerPoint.
The PowerPoint?
Right there.
Okay. Right. Well, I'm here and I'm open to chat if people are there to chat at me. I have nothing on my chat screen at the moment, so if you do have a point that you raised, could you type it in again, please?
I can read them for you.
Okay, please do.
Okay, so you answered the question about case reviews
Yep.
in the same way. An option to reach out to IGED editors to ask if an idea they have is worth pursuing. In other words, run the idea for a case report by you first before writing it and
Okay.
getting rejected.
So why don't I just take these one at a time, because I'll never remember all that lot. Thanks, Carly. I got that one. Okay, can you reach out to the editor first? The answer is yes in my case. I'm not going to guarantee that for other IGED editors. That would be a bit cruel. But by all means, if you've got a case where you're thinking this is of interest, I'm perfectly happy. Just drop me a line at my address. You can find that easily enough online at Sheffield. And I'm more than happy to kind of give an idea about whether I think it's got potential. What was the next one, Dawn?
I don't see any other questions.
You had there were about 3 that you read out just now. I didn't know if there were others.
Yeah, it was all together. Is there an option to reach out to the IGED editors?
Okay, what were the other bits in there?
It said, in other words, run the idea for a case report by you first, which you've already addressed. So
okay, yeah, I mean our goal is not to be scary. The goal is to get this stuff out there so that more people will write. I mean, I've been around for quite a few years. You won't be able to tell that obviously because I look so young and dashing. But there does come a point where you think it's really nice to see a new name in the journal, because every new name that comes up as an author is a new bit of the future. And that really matters to us. You know, it's really important that we get new people on board. So if you've got a question, just drop me a line about it. I'm absolutely fine with that one.
That's it. I don't see any other questions.
Okay. If anyone has another question, do raise it. Otherwise, I'm going to let you go home. And that would be a terrible thing you'll have to do. Okay. Well, I've even managed to, I'm getting so impressive with this stuff. I've even managed to find people's names on there. If any of you are going to be at the international conference, when is it? March? Dawn, you know when these things are.
St. Patrick's Day weekend in New York.
Okay. Well, if any of you are going to be at St. Patrick's Day weekend at the conference in New York, do come and say hi. Similarly, if you're going to be if any of you are going to be at the Eating Disorders Research Society in Sydney, do come and say hi. If you've got questions about this stuff, bring them along, or just come and tell me off about something. I'm fine with any of that lot. Okay. In that case, I will see you soon, guys. I hope you have a lovely time thinking what questions have I got, and have a good evening, afternoon, morning, wherever you happen to be.
Thank you, Glenn.
Okay.